Morning, everyone. Thank you very much for joining us today. We'll just give everyone a few minutes to join and then we will get started. Great, we'll just make a start. Just watching the numbers creeping up. So thank you very much for joining us this morning, everyone, and welcome to this morning's virtual information seminar on limb-girdle muscular dystrophy. I'm Jackie Monroe and I'm Head of Regional Support, Outreach and Information at MD UK. We have a very packed agenda this morning with a fantastic array of speakers. We'll be splitting the session into two parts, beginning with a discussion on research and a chance to ask any questions you might have on that topic. We'll then move on to discuss living with limb-girdle muscular dystrophy from both a child and adult perspective, where we'll have a general discussion and focus on answering your questions. As well as covering as many questions as we can that have been submitted in advance, we'll be using the Q&A function, which you should be able to see at the bottom of your screen. Please type your questions or comments and we'll feed them into the discussion. To help us manage the technical side of the event, we won't be calling on the audience to ask their questions directly. Any questions we don't manage to cover or don't know the answers to, we'll seek to answer through our website afterwards. So before we begin, I note that our helpline is available to anyone affected by muscle wasting conditions, and do please contact us if you have any questions or are in need of support. We can help you with information and can either support you directly or point you to where you can access support. So the number and email address were shared at the beginning of the seminar, but you can call us on 0800 652 6352. Our helpline's open Monday to Thursday, 10 AM to 2 PM, or you can email us at info@musculardystrophyuk.org. And finally, just a reminder that we are recording today's session and it will be made available on our YouTube channel over the next few days. So we'd like to thank our sponsors today, PTC Therapeutics. So PTC Therapeutics have kindly sponsored this virtual seminar, but have no control or influence over the event or its content. So my colleague, Dr. Charlotte Roy, who's MD UK's Research Communications Manager, will be chairing the first part of today's session. And to start us off this morning, Charlotte will introduce our first speaker. I'll just hand over to you, Charlotte.
Thanks, Jackie. Good morning, everyone, and thanks for joining us for the research part of this session. We have 3 brilliant speakers this morning, and as Jackie mentioned, there will be time for questions between our speakers. So if you have any research-related questions, please feel free to submit these using the Q&A function at the bottom of your screen. To start the session, I'm delighted to introduce Professor Chiara Marino Botello, who is a consultant neurologist at the John Walton Muscular Dystrophy Research Centre at Newcastle University. Today, she will be sharing some information about the highly specialised service for limb-girdle muscular dystrophy and support available for people living with the condition. Over to you, Chiara.
Thank you. Thank you for inviting me, and it's great to be here. So I thought I'll just share some information on the highly specialized service for rare neuromuscular diseases, and just bear with me whilst I start sharing the few slides that I have. Okay, can everyone see okay?
Yeah, can all see.
Yeah,
thank you.
Okay, so it's just to make everyone aware of some diagnostic and clinical management resources that we have available to everyone in the UK. And so there are 4 highly specialized services for neuromuscular diseases that cover the whole of the UK. And one specific is for limb-girdle muscular dystrophies and distal myopathy that we run in Newcastle. And then there are other 3 services for congenital myasthenic syndrome, congenital muscular dystrophies and myopathy, and skeletal channelopathies that are run by the teams, but we work very closely together. So we fall under the same highly specialized service essentially. And just the services provide all essentially a clinical review or remote advice, so a clinical appointments to patients, whether they're diagnosed or undiagnosed. So we suspect diagnosis of one of these group of diseases. We provide pathologic diagnostic service, which means that we can receive a muscle biopsy tissue and that to be analyzed in our labs. And then we provide genetic testing, so that test to confirm the diagnosis that is done on a blood sample. And then we review in our weekly MDT, so the multidisciplinary team meeting that brings different experts together. And we review all of the evidence and provide an advice letter to the referring clinician and to the patient too. And that includes advice on the diagnostic and side of things. So is the diagnosis confirmed? If not, what next to do? Which other tests are required? Then we provide some advice on management, whether it's some specific condition you require, for example, cardiac screening, respiratory monitoring, and so on. Advice on general management and of the condition, genetic counselling. And that is also just a comprehensive advice. Patient can come to our clinic as well. Often, if they are not from the area, then we see them as a one-off and then refer them back to the referring clinician with that specific advice. And so what are actually highly specialized services? So these are multidisciplinary clinical services available for adults and children. They were sort of designed as diagnostic service for patients with a suspected inherited neuromuscular condition. However, they also provide clinical management. So we do see patients that have a confirmed diagnosis to provide that additional management, for example, on exercise, management of pain, and cardiac respiratory management. What is the care required? What are the standards of care required for that specific disease? Over the years, the allied healthcare professional input for symptom management and advice and support for health and social care issues has grown, and there is more demand for that. We provide a specialist physiotherapy assessment and advice in that clinic. And then we provide comprehensive information for patient and carers, signposts, for example, to patient registries or other resources available, for example, through MDUK, fact sheets and alert cards that are available are given out. And then through Care Advisor, we provide also advice for what other social care aspects that could be involved. And also we deliver and arrange meetings with people living with the disease and have forums for education, information, National Patient Day. And also, because there's also a research session, we signpost, for example, if there's a clinical research available for that specific condition, a clinical trial, whether it's a drug, non-drug trial, natural history, and you will hear more about it from Meredith, and so signpost to available studies, whether they are, mostly we would focus on those that we are aware of running in the UK. Specific for Newcastle, the team is composed of clinical academic team that specifically deliver the clinics, so patient-facing appointments, whether they are remote or in person. And then we generally provide for local patient a 1 year follow-up appointment. And for non-local patient, we refer to them to the nearest neuromuscular center. As I said, we are able to receive muscle sample for diagnostics. So we, as part of the service, we have a laboratory that will analyze and slice the tissue very thinly to look under the microscope and add to it different stainings so that we can help understand what's going on in the muscle. And then from a molecular point of view, so the genetic testing side of it, we have several scientists that work with the team and are able to provide specific tests for the girdle muscular dystrophies and distal myopathies. And then as part of the weekly meeting, we review all of the information and provide comprehensive advice. So that's sort of the highly specialized service in a nutshell. And so it's just to make you aware that you can request to come and see the team, or whether it's in person or remotely, but you need to be referred through your neuromuscular specialist typically. Thank you.
Brilliant. Thank you so much, Cara. So yeah, just to clarify on that, you'd need to ask your clinician or doctor to refer you to be able to access to the services.
Yeah.
Brilliant. Thank you.
We sometimes accept a referral from the GP to speed up the process or not, if you don't, so that, you know, you don't need to wait too many weeks to get to see first a neurologist or neuromuscular clinician. But if you're already on a neuromuscular clinician, then that's the easiest to do, to ask for a second opinion to the highly specialized service.
Brilliant, thank you. And if someone had specific questions about research and clinical trials, the best way again would be to get the referral, then they can talk to the specialist service about it.
Yes, and then we generally also identify who is best amongst our team, because obviously we have different, whilst we work as one team, there is different expertise and on, for example, clinical trials and research interests. So we would also try and make sure that, if possible, the best placed person to talk about that is available that day in clinic.
Brilliant, thank you ever so much. Okay, we're going to move now over to our next speaker, who is Dr. Meredith James. Dr. James is a specialist, a clinical specialist neuromuscular physiotherapist, also at the John Walton Muscular Dystrophy Research Centre at Newcastle University. Meredith recently completed a PhD where she developed an assessment tool to help measure changes in progression of limb-girdle muscular dystrophy, which is now being used in clinical trials to help determine if a treatment is working. She's here today to talk about some of the latest research in limb-girdle muscular dystrophy. So over to you, Meredith.
Thanks, Charlotte. I'll attempt to win with the technology and share my screen and my slides, and hopefully everything will work today. Thank you very much to MD UK for the invitation. Have the slides come up now?
Yeah, slides are there.
Everyone?
Brilliant, thank you.
Brilliant, thank you. And those are my disclosures. This is a little history lesson. It's now just over 70 years since the limb-girdle muscular dystrophies were first identified and described by two neurologists up in Newcastle. And while I'm not going to take us on a history lesson of the last 70 years, I will focus on changes in limb girdles, particularly over the last 10 years. There's been quite a lot of research and our first clinical trials, so I'll focus on that today. But we have Lord Walton, for whom our centre in Newcastle is named after, and Fred Nattrass, who first identified that within the patients they were seeing in the north, that there was a group of patients who had a particular presentation that affected the shoulder and pelvic girdles, and they coined the term limb-girdle muscular dystrophy. And so for those individuals on the call, you'll be aware that this does affect the muscles around your pelvis and your shoulders, but it can also affect your lower legs and your arms as well. And over the last few years, we've had a bit of a name change as well. So if you used to have a limb girdle type that was called 2B or 2A, it's now called R with a number, or D if you have a dominant inherited form. And I'll show you the reason for that. Generally, the dominant forms, which are less common, present in adulthood, and the recessive forms, which used to be called the type 2s, are now called the type Rs, can present in childhood to early adulthood. And generally, progression would be described as slow, but we know for some people, their progression of disease can be quite rapid. And 10 years ago, we didn't really have a great way of measuring that. We could measure your strength in clinic, but it wasn't really predictive to help us better give you time to manage changes. Now, this is the reason we had to, the medical colleagues came up with the need to change the nomenclature. We ran out of letters of the alphabet. We got to Z. We couldn't, and it would be a bit clunky to then go AABB. So the limb girdles changed from type 1 and type 2 with a letter to this new naming that's got D for dominant, R for recessive, and a number. And we hopefully will not be running out of numbers anytime soon. Okay, so you may see that your type of limb girdle could be named three ways. It could be named for the protein that might be involved, so something like dysferlin in limb girdle 2B or R2. So just be aware that there's three different ways to sort of name your limb girdle subtype at the moment, but they all relate to the same subtype. I'm going to talk a little bit about natural history and why that's important. And so our research in the last 10 years particularly has really focused on natural history, and that's about capturing how the condition impacts you in your daily life across all your body systems, so your muscles and your breathing and your heart and your well-being. And when we do natural history studies, we get multiple places to collect data in exactly the same way, so we can start comparing apples with apples, because these are really, really rare conditions. And so in order to better inform the science and to help the drug companies, we all need to talk the same language about how the condition's affecting people. And so our natural history studies are also key clinically to the management and are giving you the right advice at the right time. It allows us to monitor change in the condition. We use the assessments that we determine are appropriate in natural history studies as the tests in drug trials to determine if an interventional drug trial is working. The assessments aren't always right, so we often need to make them better. So natural history allows us to really critique how we test things and make them better, to give those improvements to the assessments. And you'll see over the last 20 years or so, the number of studies that have looked at limb-girdle muscular dystrophy as a natural history study has rapidly increased, and we're getting much better coverage across many of the subtypes now. Originally, 20 years ago, there was only a couple of studies, but at the moment, there are 6 consecutive natural history studies running globally, several of them in the UK, and I'll come to those in a minute, where we're trying to understand the condition better so that we can allow better predictions and creating that crystal ball to try and give you individualized information about what you can expect to change, what won't change, and how to better prepare for the future. And it's because of data. So we all hear about data and AI and how we can better model and improve things by using the computers and data. But we have to have really good high quality data. And so when we have a look at you in clinic and we have a look in a natural history study, we want to understand what the pattern of muscle involvement is. We know each limb girdle subtype can have different patterns of muscles involved. We don't know why, but we do know that that's the case. We should understand which assessments, if we're going to see you in clinic and we've got 10 minutes or we've got an hour, what's going to be the most important thing to use in the clinic to measure, to then tell us how things, to be able to then inform you, your individual trajectory of change and what might be coming in your future in 6 months, or what might be coming in 12 or 24 months, or even a change that you can expect not to happen, which gives us better chance of advising and doing things like equipment prescription or exercise therapy or managing your movement better. So that's all helps us improve the care by doing that research in natural history studies. One of the big studies in limb girdle, in fact, it's the largest and longest natural history study for any limb girdle, is the dysferlinopathy study that was led from Newcastle and the Jane Foundation, who's the patient charity specifically for dysferlinopathy. And at that stage, when we started this study over 10 years ago, we didn't have disease-specific tools for limb-girdle muscular dystrophy. There was beginnings of clinical research, but no drug trials. And so this study's really allowed us not only for dysferlinopathy, but to take everything we learnt in dysferlin and apply it to all the other limb-girdle subtypes that we're studying. So it was an international study. And the reason it needed to be international is that all of these limb-girdle subtypes are super rare. And so in order to get enough patients, and we had about 200 people, so it's quite difficult to find lots of patients with limb girdle. It's a bit different to trying to find patients with asthma or back pain. It's, you know, there's not very many of you. You're all very precious and important. So we ran the study at 15 sites in 9 countries over 3 years, and we had patients between 10 and 88 years old, and we studied them with the same tests in all the hospitals at all those sites. In order to do, and what we needed to do was we needed to understand that everyone's an individual, but we need to make sure that we're measuring everybody's experience of how the disease is impacting them in their life, in their movement, in their breathing, in their muscles with MRI. And so this natural history study that allowed us to better determine what tests would actually be appropriate and make sure that we weren't doing things that weren't helpful to people. Doing lots of muscle strength testing isn't really helpful in managing the condition. So we came up with some new tests. And so something that some of you may have had in clinic, or if anyone's a participant in one of the studies in the UK, we've come up with a new scale where we ask you to do lots of different tasks, like getting on the bed, being able to roll over or lift up your head, if you're able to stand, looking at you standing and walking around and things like that. But when we test you in clinic and we make you do all these things, we also have to make sure it actually reflects what things you're having difficulty with at home. And so some of the research was looking at these patient questionnaires that we may ask you to describe if things are easy or difficult or impossible at home with daily activities like toileting and dressing. And we needed to make sure what we asked in clinic was also really relevant to what was happening at home. So that research has been ongoing. And my colleague, Emma Robinson, has been specifically looking at what happens to people's quality of life and social life when standing up from a chair becomes difficult. And so we know that as you all know very, very well, that as standing up from a chair becomes more troublesome, you lose a lot of the spontaneity in going out, and you start having to plan your activities, and you may avoid going to certain places because you're not sure if you're able to get out of the chair. And so as clinicians, it's really important that we check about that and make sure that we get an occupational therapist involved or look at equipment that can help guide you from a sitting to a standing position more independently. One of the other important things from the research was some people may be aware that within dysphallopathy, there was lots of different ways of calling the disease. Some people had a diagnosis called Meioshi myopathy, which was from one of the Japanese neurologists originally. Some people were diagnosed and it was called limb-girdle 2B. But we didn't know if it was just different manifestations or if they were different diseases. And this is important for future entry into drug trials and things like that, or for future treatments, that we need to understand if they're the same disease. So we use muscle strength testing and MRI and our functional scale, and we compared everyone with the two diagnoses around the world. And what my colleague, Dr. Ursula Moore, was able to confirm was that these are in fact the same disease. So this is all dysphallopathy, which means that there's equity in entry into future clinical trials and treatments. My colleague, Professor Jordi Diaz-Manera, has particular interest in MRI, and so we've been using MRI to be able to look at muscles in great detail and understand which muscles are being affected and how fast they're changing. And what we're looking to do is to be able to see also in future drug trials if the MRI might change sooner than your overall muscle function, because that could be really, really helpful to show us earlier that a treatment may be working. It's also really important because it might help us predict change too by utilising the MRI. There's a lot of talk about real-world data, and I'm sure a lot of us may have on a device that measures our stepping or our sleeping and looking at that. So we're also interested, and there's a lot of research going on around digital outcome measures. There's some portable measures of walking where we can put an insole in your shoe and have a look about how your walking's changed. We can have a look using a Microsoft gaming system to have a look at how upper limb function's going. We've been looking at remote testing as well in the home to see what's feasible in the home to try and reduce the burden of having to come into the hospital. And so there's a lot of research around those things at the moment as well to try and get that what they call the real world data. All of this natural history data and building interest in limb-girdle muscular dystrophy in more clinicians around the world allows us to then develop standards of care so that we can actually advise other clinicians and decide as a group what's really important to measure when someone does come to clinic, and to make sure that we have the best informed treatment and management and counselling regardless of your location around the world. So there's been a few initiatives starting with dysphallopathy, moving on to the sarcoglycanopathies and limb-girdle R9 or 2I that have started this process to develop publications around standards of care. And so that just makes sure that we put in all the members of the team and includes the genetics and the diagnosis, and looking at exercise and physiotherapy, occupational therapy, respiratory care, looking at endocrine and immunology, and then also looking at pregnancy and other care considerations. Because as you can imagine, your normal obstetrician might not have ever come across somebody with limb-girdle muscular dystrophy before, and there's not a lot of evidence out there, so sharing practice is really important. Now, for the interventional drug trials, so at the moment, there isn't an approved treatment of a drug for limb-girdle muscular dystrophies. However, as you can see, in the last 10 years, we've got a massive increase in the number of studies that are undertaking drug trials in a few different forms of limb-girdle muscular dystrophy. So last year, Sarepta had a gene therapy study for limb-girdle type R4, and then they also had an early phase where they just dosed 2 patients who had limb-girdle R2 or dysferlinopathy. In the UK, and for the limb-girdle 2E or R4 or sarcoglycanopathy study, that study was conducted in Newcastle and dosed the first patient in Europe for that study. The phase 1 with dysferlin, that was just in America. So that was just 2 sites in America and 2 patients. ML Bio are looking at a study in limb-girdle R9 or 2I or FKRP, and that's a study of ribitol, which again, we have 2 sites in the UK. I'll go into that in a little bit more detail. Ask Bio also looking at limb-girdle R9, and they've got a gene therapy study, but that's just in America. And then Atomio, which is a French company, they are also looking at limb-girdle R9 and have started a gene therapy study. And what's been a really good benefit from the natural history data is that these studies are all using very, very similar outcome measures. So we can use what we learned in the natural history studies and our clinical practice to help pharmaceutical companies use the right assessments to measure things that are important to patients in the drug trials. So Sarepta, a lot of people may have heard around Sarepta. They have quite a big limb-girdle muscular dystrophy program. You can see here in the blue bars that they're working on 3 different gene therapies at the moment. All 3 are coming into clinical trials, which means they're now testing on patients. So the R4 study is the one that's already underway in Newcastle, and the enrolment has closed for that one. The R3 is underway, and the dysferlin one was America only and just a couple of patients. But obviously, as these things move forward, they test on a couple of people, and if it's successful, then they would hopefully move to larger numbers. So the gene therapy study for limb-girdle R4 was called the EMERGENE study. And so we have this study at 1 UK site, so just in our site in Newcastle, and it's a global study, so there's other sites in Europe and America. And what they're looking for first in this study is to see if the gene therapy will mean that patients who receive the treatment improve the expression of the protein in the muscle. Okay, so because that's the cause of the limb-girdles, that you're missing the protein inside the muscle. So that's underway. We don't have any results from it yet, but it's been fully enrolled with, I think, 16 patients internationally. For Atomio, who are looking at limb-girdle R9 first, they've done their first studies of their gene therapy, trying to come up with what amount of medication, what amount of gene therapy is the right amount. And then this program is continuing with some more patients this year, we understand. And then they're also looking at limb-girdle R5, one of the other sarcoglycanopathies. They haven't dosed a patient yet, but we can see here that it's in progress. And then this company's also announced that they're also going to be looking at calpainopathy, so limb-girdle R1. The ML Bio or Bridge Bio study is called Fortify, and that's the limb-girdle R9 study. And that's got 2 UK sites. There's Newcastle and also Great Ormond Street. This is another international study of about 100 patients, and that's finished enrolling now. And so they want to understand using a randomized placebo-controlled trial. So double-blind, the patients don't know if they're receiving the treatment. The clinical team that are assessing them don't know if the patients have been treated or not. Some of the patients will be receiving placebo and some will be receiving the drug. And it's a long-term study because it's a often slowly changing condition. It's a 3-year study. Again, using lots of the functional things that we've developed in the previous natural history work, and then also looking particularly to see if we can get an earlier change in the glycosylated alpha dystroglycan to see if there is a change occurring in the muscle sooner than we see change with breathing or walking, for instance. So we hopefully will get some results for that study this year. AskBio, this is an American-only gene therapy study in FKRP. So they've enrolled some patients and this study is ongoing, but as far as we're aware, just in the USA for the time being. So what's been really important and something that the patient community have done is build the community and build the interest in each subtype and bring patient foundations together and utilising MDUK to understand where the UK limb-girdle community are and have people engaged. The community globally have been able to go to the regulators like the FDA in America to tell them what's important to them and what's acceptable to them in drug therapy trials and what sort of change or stabilization would be meaningful to the patient community with a treatment. And that's really important for the regulators to understand how the disease impacts life and what risks people would be willing to take and what sort of change people would be willing to accept. There's been a number of limb-girdle patient days, some disease-specific and some more generic. Obviously, we have today as the webinar, but there's also been the international limb-girdle patient conferences in America, and we had a R9 specific one in Amsterdam last year. As Chiara mentioned, we had a National Patient Day in 2023 for individuals with limb-girdle muscular dystrophy, and there's lots of international events going on to try and build the community, link everybody together, and let the scientific community know that we continue to need to drive research and we would like to see interventional studies for our patients. And so particularly in the last 10 years, we've learned that we really need to do these natural history studies. They are, for those people on the call that are already participants in some of the ones we run, they are time consuming. You have busy lives, you're trying to work, to have families, and we know they take time, but they are absolutely priceless to driving the science forward in limb-girdle. And we need the partnership of the patient community to make sure that what we do in these studies actually is relevant to your daily life living with LGMD. And then that way we know where everybody is who has the condition, and that will lead me on to Helen talking about the registries shortly, because an engaged patient community is invaluable to drive science forward. So in the next 10 years, we want to make sure that we're getting the voice of everybody globally, so that we ensure that we adopt an every patient matters approach to all the clinicians that see somebody with LGMD. We've got some new studies starting in Newcastle, which I'll go to in a second. And we also have some clinical projects starting with the highly specialised service around making sure that we are collecting really important clinical data for patients with limb-girdle and looking to roll that out across the UK. There's some really lovely podcasts, and obviously I'll just also tag the virtual therapeutic support group that MDUK run for individuals with limb-girdle. This information's on the MDUK website. Louise Halling also had her series on the BBC4, Walks Like a Duck. And Cara Stavage, who one of the Welsh patients with limb-girdle, she also has been publishing her Unbalanced podcast, which is a really good listen and really, really supportive. So for anybody in the UK, in terms of research at the moment, we have got a new study from Sarepta, the Journey study, which is a natural history study, and that's for patients with genetically confirmed 2A or calpainopathy. And we're also opening soon a new study for patients that are recently diagnosed with limb girdle R2 or 2B or dysvelinopathy, who are very early, recently diagnosed or very early on in the disease process. And the email is there for anyone who may like to get some more information about participating in clinical research in the UK and has limb girdle muscular dystrophy. And why participate? Pain, you have to come to Newcastle. You know, we get proper weather up north. Sometimes it gets quite windy and snowy up there. But why participate and have to interrupt daily life to inconvenience yourself to go in a natural history study? Well, I put some quotes from some of our patients, and I promise I didn't bribe them to have to say those quotes about why they participate. Some of our patients with dysferlin have been with us for over 10 years, coming back to Newcastle every year to see and participate in the clinical outcome study for dysferlinopathy. I think it's a good opportunity to connect with a specialist muscle team who know your condition. You don't have to explain anything about your condition because they understand what it's like and want to make sure that we're doing our absolute utmost to drive the science forward and make positive changes for people. There's also a limb girdle conference in Florida, which I think they might be live streaming. There's the limb girdle patient news as well, specifically for individuals with limb girdle. It's a free magazine that you can get via email every quarter. And on that note, I'll say thank you very much to the team and give over to Helen so you can talk about why the registries are so important. Thank you.
Thanks, Meredith. That was a really great presentation and overview of the research. It's fantastic to see that so many more clinical trials and research are coming through over the last 10 years as well. We do have a couple of questions. So one of them is that there seems to be an emphasis on limb girdle R9 in clinical trials. Do you know where the reason why that seems to have more of a focus than other forms?
To be honest, it's one of the easier ones to create a medication to treat. So that's why it's often a focus. It's also, yeah, that's the main focus. It's genetically easier to create a treatment. Some of the other limb girdles have very big DNA that when you give gene therapy, this is my very basic, very basic understanding. But in order to deliver gene therapy to an individual with limb girdle and replace the protein in order to produce and replace the protein that's missing, you need to be able to origami up that DNA message and attach it to a virus to get to the cells. And if that message is really long, it's very difficult to fold it small enough to get into the muscle cells. So that's a bit of a limitation. So R9, for pharmaceutical companies, R9 appears to be a good disease for them to work with more easily.
Thank you. Yeah, so it's a good starting point which they can then learn and take forward for hopefully for other forms as well. Someone's mentioned about a company, Myopax, and whether there are any potential future clinical trials from them, if you're aware of anything.
I haven't seen anything. I just checked on clinicaltrials.gov yesterday just to see if anything new had appeared from some of those smaller biotechs, but nothing from them on clinicaltrials.gov. And that's the website where if you are going to run an interventional study, that would have to be listed on there. So watch that space.
Brilliant, thank you. You spoke about some of the clinical trials that are happening. Somebody's wondering if they are from another country, if they can participate in the UK. Obviously, you mentioned that some of them are recruiting elsewhere as well in Europe. So is that something that someone just should continue to talk with their clinician about?
Yep, so talk to your local clinician first, make sure you're chatting to your neuromuscular consultant. There is sometimes potential to travel. It's not always possible for all clinical trials. So the first starting point would be your local clinician to have that discussion.
Brilliant, thank you. And I had a question as well. You mentioned AI at one point during the presentation, especially about data. And I know people kind of panic a little bit when they hear AI, but what do you think? How is AI going to potentially help, especially around those natural history studies and helping learnings from those?
Okay, so we've got it a little bit in practice already. So what we've been able to do, we've taken lots of MRI, so just taking the picture of the muscle MRIs and understanding when we look at a picture of MRI how much muscle there is or how much might have changed to fat and fibrotic tissue. And then clinicians have looked and graded those, and then the computers graded those. And then because we know that's good quality data that's reliable, that's been fed into essentially an AI machine, and it's allowed us to understand and the machine to learn the patterns of involvement in different muscular dystrophies. So AI at the moment, there's a project again run by Jordi Diaz-Manera looking at using AI for diagnosis of muscular dystrophies, particularly around limb girdles who have all, a slight subtle difference in the muscles that can be involved. And so the machine's being trained on the data from the MRIs to predict the diagnosis of someone from the pattern of muscle involvement that they have on their MRI. And then for us, in terms of my interest is always function and movement as a physio. And so for us, we can look at combining the data from the MRI with the data from the function that we do, potentially from the genetics, to try and understand with the computer learning, is there ways we can better predict change? Because I think giving people, for me, it's really important that we give people a better crystal ball about what's coming in their future and time to make those adjustments. So I think there's a really good opportunity with this high quality data we've been collecting internationally, where we are now all talking the same measurements and it's all comparing apples with apples now, which is what we need, because there's not a lot of individuals with limb girdle. So again, taking that every patient, every appointment matters approach will hopefully help us use the AI technology to better understand how things change over time.
Brilliant. And I think that's so important, like you say, being able to potentially provide more people at diagnosis, potentially how they're going to progress and what that's going to look like. I think the use of AI is fascinating in this as well. And just a final one about digital endpoints. I think this is a really important kind of area of research, because often when we put people doing clinical trials and things and ask them to do certain things to test the function, obviously they may feel tired because of one thing or another. They had a busy day yesterday. So how far away do you think we are from those digital endpoints and the impact that they could have in research?
Yeah, so I think there's lots of things we can measure at home. And certainly when we look outside of muscle disease, you can measure your heart rate at home, you can measure your blood pressure at home, you can measure your movement. What we're trying to understand is what about measuring you at home that's different to measuring you in the clinic is important, and and how can we reliably measure it? So does walking matter? Well, it only matters if you can walk. So for people that aren't walking so well, what we should be looking at upper limb function too. So there's lots of research going underway. We're learning from Duchenne muscular dystrophy first, because they've been looking at a lot of different activity monitors to see if activity monitoring is helpful, and it can be really useful. We have to be considerate of weather influences in the UK particularly. Our weather is, people do less in the winter, which makes it look like they could be getting worse. So we need to be really sensible about when we time activity monitoring and making sure we account for seasonal changes. But there is an interest in looking at how fast people who can walk do walk at home, and that could be really useful. And I think we're going to try and incorporate some of those digital tools into more of our research. So we've been doing a lot of gait work in the lab, but we're going to be doing future work in the home with activity monitorers.
Brilliant, exciting area. Looking forward to seeing that progress. Right, I'm going to move over now to Helen Walker. So thank you so much, Meredith. Helen is a patient registries project manager, again, at the John Walton Muscular Dystrophy Research Centre in Newcastle. So registries collect data from people affected by conditions such as limb girdle muscular dystrophy. And the aim is to support research and help better understand the condition. And Helen's going to give us a little bit more information about them now. So over to you, Helen.
Hi, everyone. I'll just share the slides. Okay. So hopefully you can see those now.
Yeah, all of them. Thank you.
Okay, so as mentioned, I'm not Sam MacDonald. My name's Helen. Sam, unfortunately, is unwell today, so I'm going to cover the webinar slides for him. So as we mentioned, the registries that we run here at the John Walton Centre, we run some national registries, but we also run some global registries, and 2 of those are for types of limb girdle. So this is Sam when he's well. So we run the registries for collagen 6 related dystrophies, the types you can see on the screen here. And we also run the global FKRP registry that collects information on LGMD-R9 2I. So patient registries are databases. We collect information from people who have a specific condition, and that data can be used to facilitate research. The data we collect is standardized from all participants. We collect core data sets when they exist, which then means that data can be combined with other data repositories anonymously and shared to help with global research efforts as well. And registries can be either patient entered or clinician entered or dual reported. Ours are both. They're the dual reported type, so they are all patient initiated. If you're interested in signing up for any of the registries, I'll tell you a bit about how to do that in a moment. It always comes from the patients first, so you would come and find out information about what it means to take part in the registry, and then you will sign a consent form. The clinician entered data part of it comes from if patients want to invite their clinician to also join the registry, they can then sign an additional consent form and the clinician can add some supplementary data, but that only happens if the patient wants that to happen. So this is a bit about what the registry does with the data that we get from the patients that kindly share that with us. So we can support research into how widespread the condition is and how symptoms progress. We can support scientific research questions. They can come from academics, from healthcare, or from industry professionals. We can inform, understand, and provide data to support national standards of care. And we can also help to plan and recruit patients to clinical trials and studies. And registries are also a really important two-way flow for getting disease-specific information. So really important link between the research community and the patient community, especially for these rare conditions where we have people all over the globe. So these are some of the examples that the global FKRP registry has supported in the last few years. So the feasibility means like the planning of the clinical trials, so providing information to help those get planned in the first place. And then the trial recruitment is where we will help to find patients that meet the eligibility criteria for that trial to help the trial be able to get fully recruited and meet its criteria. So the way we do recruitment support within the registries, we collect information, obviously some identifiable information that you give us when you sign up, but we never share any of that externally. So if a clinical trial is struggling to recruit, they will come to the registry and they'll ask us to send out information to people who might be eligible. So we go through the data that has been provided. So things like your subtype of your condition, there may be things like mobility criteria, age range, things like that. We can go through and look at all the data about the people that we think are likely to be eligible. And we then send out trial information directly to the registry participants. So at no point will we ever send any names, phone numbers, contact information to any third parties. It's then up to the individual patients to decide if they want to get in touch with the clinical trial sites and sign up to try and get a screening assessment and take part in that trial. So this is a little bit on why registries are important. And this image was produced by Genomics England, and we've added it to help understand the role of patient registries in rare diseases. So it shows that while there are diseases that are individually rare, together they can make up a large population. So we think there's about 3.5 million people in the UK that have some kind of a rare disease. We know that the collagen 6 dystrophies are very rare conditions. The estimated prevalence of Ulrich CMD and Bethlem myopathy in Northern England is around 1 in 100,000 people. So because of this rareness, an individual clinic or doctor might only see a handful of people with a collagen 6 related diagnosis. And for that individual doctor, it would then be really difficult to have an accurate picture of all the different ways that these conditions can present or how they can affect people. But by bringing data together from individuals, not just nationally, but internationally, we can help build up a more accurate picture of these conditions. So this some of the ways that registries help to solve some challenges that exist out there. We know that obviously there's limited data available for meaningful research for rare diseases. It's one of the things we can help with, collecting data national on international scale, and we can increase sample sizes. We also know that there's a challenge where data is collected separately. It can be collected in different formats and can be difficult to combine. By using the standardized data sets and core data sets wherever we can and aligning with other disease data collection activities, we standardize this, make it easier for the data to be used for research. I've already talked a little bit about how we can support trial recruitment. And again, it's a barrier, helps overcome barriers to patient engagement with research by sending information out through the registry and having that networking aspect to it. So some of the benefits of joining the registry, we share relevant news and developments from the limb-girdle field through newsletters and through emails and from social media. And we can keep you informed about research opportunities and help direct the research community towards what matters most to you as patients and families. We also contribute to publications, and there's a lot of extra information on the registry websites themselves as well. So just a few more key points just to really drive home here. No identifiable data is ever shared externally. If researchers want to access the data in the registry, they submit a request. This is approved by our independent steering committee, who have a very thorough governance process that they go through. And we share data reports externally. We don't ever let people come and just rummage around in the registry. So this is part of the makeup of the steering committee. We have expert clinicians and researchers. We have affected patients and families, and we have patient advocacy groups. The recruitment support is indirect. That's again, we don't ever share any identifiable information externally. So this is how you can find out if there is a limb-girdle registry for your subtype. I think there are a lot of them out there. If you scan the QR code on the screen there with your mobile phone, that will take you to a site that has a list of all the different registries that we know that exist for all the different subtypes. The FKRP and the collagen 6 are here at Newcastle University, but there's other registries based all over the world that we collaborate with. That was the presentation on the registries. Thank you for listening.
Thanks so much, Helen. It's really interesting. In terms of if someone was being involved in a registry, how much time would it kind of take out of their life to kind of be involved?
So we ask that people update their registry questionnaires once a year. They can do it more often than that if they have a significant update that they want to share, but once a year is normally fine. It can take sort of between 5 to 10 minutes maybe to fill in the questionnaires. We try and keep the number of mandatory questions as minimal as possible. So if you're in a real hurry, only do the most essential ones, but there's quite a few optional questions on there as well. So if you have a bit more time, we will collect more data, and we review the questionnaires that are on there fairly regularly as well.
Thank you. Chiara, did you have something to add?
Yeah, I was just wanted to obviously Helen has a brilliant presentation but stress the importance of patient voice here and as Meredith said, there are some outcomes that can be completed in the home setting, and some of these are also aside of the physical assessment, respiratory function, activity monitors, those are patient reported outcomes and perceived benefit, which is so different to often is like what I perceive in clinic might be that quality of life or may not see a change. It may be subtle that I can't objectively assess it, but there might be a perceived benefit to the individual living with the disease. So it's the registries have really a role here to capture that change, particularly when it comes to having a drug hopefully being approved and coming to the clinical setting and sort of compassionate, and then the approval pathway. And we know how lengthy that that approval pathway is, and regulators are looking more and more at utilizing patient-reported outcomes to contribute to the evidence of efficacy and benefit. And so if people living with the disease get used to go into the registries even before treatment is there, we have, that will contribute to having strong pool of data with that patient voice captured. And we can also utilize them to assess gaps in standards of care, care provision. So there is a huge power of that patient-reported outcome.
Definitely, and I think sometimes registries don't come across as what's described as sexy research, but it is important research that can have a real benefit to people living with the condition now and in the future too. Helen, in terms of the questionnaires, that's all done online, so people can do that from the comfort of their own home?
Yeah, absolutely. It's all online on a secure website, and I think actually the FKRP website has just been updated yesterday. So there's any of you out there that are on the FKRP registry, you can go and have a look and see what you think of the new system. Yeah, but it's all online. If for whatever reason you struggle with completing it online, we do allow people to have data entry support. So if you have a family member or somebody with you that can help you do the actual entering the data, that's fine, that's allowed, as long as it's the answers are coming from the patient directly. We can also post out paper forms if it's necessary. Obviously, with being an international registry, we try not to do that unless we really have to. But yeah, that can be arranged, and we can also support via the phone as well if that's helpful. And we come to MDUK's patient days whenever we get an opportunity to as well, to meet people in person.
Brilliant, thank you. So in the interest of time, I'm going to close the research part of this seminar now. So thank you so much to Meredith, Helen and Chiara for talking today. And if we haven't answered your question, we'll make sure to try and answer them after the seminar, or if you email us at info@musculardystrophyuk.org, we'll be able to answer your questions. So pass back over to you, Jackie.
Thanks so much, Charlotte. So we'll now move on to discuss living with limb-girdle muscular dystrophy from both an adult and child perspective. So I mentioned at the beginning of the seminar, I'm Jackie Monroe and I'm Head of Regional Support Outreach and Information at Muscular Dystrophy UK. Really delighted to welcome our 5 panellists today who will be joining Dr. James, Professor Marina Bitolo and Helen Walker, and I'll help us to discuss and answer your questions. So we're being joined today by Alex Schofield, Rachel Salmon, Martin Highwood, Shan Craig and Zoe Harrison. So I'll just invite each of the panellists to make a few remarks about their experience of limb-girdle muscular dystrophy and to raise some key points about managing or living with the condition. So as I mentioned at the beginning of the seminar, we'll be covering as many questions as we can that have been submitted in advance, but we'll also be using the Q&A function, which you should be able to see at the bottom of your screen. So please type your question or comment and we'll feed them into the discussion. Any questions that we don't manage to cover today or we don't know the answers to, we'll seek to answer directly after the seminar. So if I could just come to Zoe first, if that's okay, Zoe. I know you might have to leave us a wee bit earlier. So, Zoe,
Yeah.
are you happy to kind of introduce yourself and just share some information about your experience?
Yep, absolutely. Thank you very much for having me today. So obviously my name's Zoe. I have limb-girdle muscular dystrophy type 1B. I've worked in the NHS for the past 2 years in paediatric mental health, and I've also do a lot of advocacy work. I have a podcast, and I really enjoy being able to share my lived experience to help other people. I'd say my experience of living with limb-girdle, it's been quite a journey. Obviously with the progression of the disease, it took me quite a while to kind of accept things, I'd say. I had a lot of frustration at a young age, and that's actually what inspired me to go into the NHS to help other people like myself. Because I found talking to people and the psychology route really beneficial for myself. So I'd always really recommend that to anybody that might be struggling. I personally have always found the best way that I approach things is just have a go. I always think when you first get diagnosed, you can often assume that you can't do things or that your life won't be how you want it to be. But honestly, you find your own way of doing things. I'm very happy to say that it's never stopped me in life. If anything, it's probably pushed me on more to do things. And I try and just help other people know that they're not alone, and know that as difficult as this disease is, it really isn't, the end of the world. You can still live the happy life that you want to. And I find things like this with MD UK just so helpful, to be able to meet other people like yourself, to be able to talk about your experiences and share what works for you and what doesn't. And that's really the message I always try and get across. I think, we all have good days and bad days with this disease. And I think I always say it's a journey, because it is, and everybody has their own individual journey and experience. And I just try and help people feel not so alone on that journey, really.
Thank you so much, Zoe. We're really grateful to have you with us today, and thanks for sharing that with everyone.
Thank you.
So Martin, I just wonder if it's okay, can I come to you next and you can share a bit about yourself?
Yeah, no problem at all. So thanks so much for everyone that's spoken before. It's absolutely fantastic. Meredith especially, I think I've met you before, and all the information you've given us today is absolutely awesome. And also Helen with the information about registries and everything else. It's all absolutely fantastic. I'm 50 years old, and I was diagnosed 25 years ago alongside my brother by David Hilton Jones at Oxford. My brother's 2 years older than me, so I see what progression looks like. But I'm your guy. Anybody that's listening today, I'm your guy on the inside. I work for Muscular Dystrophy UK in partnerships and with our ambassadors like Gabby Logan and John Ritterton. I'm an advocacy and disability rights campaigner. I'm a fundraiser. My family fund has raised £330,000 and hopefully get to 350 this year. And I have all the experience across the access card, access to DLA, access to PIP, access to the WAV and Motability. I have a wheelchair accessible vehicle. I've been through the process of the Joseph Patrick Trust with Muscular Dystrophy UK getting access to disability aids and equipment. I've had a wet room fitted, and I've had a drive recently put on the front of my house to speak to the appropriate people about what access is like, and in the real world of people living with disabilities, not somebody who's not living with disabilities looking at something thinking it's accessible. So I could say so much. Everybody that's spoken today has really impressed me and inspired me. But one thing I would say that we can do immediately really is to take care of ourselves if we're living with a limb girdle muscular dystrophy. You know, my muscle memory still allows me to be ambulant and to move around my house, and I would just try to give what I would say to people is try to take care of your surroundings immediately, because I don't think I've ever been hurt by muscular dystrophy directly. I've been hurt by the environment around me. So sharp edges must go. And you know, the things I've done have just been, like I said, due to my environment, my coccyx, my fractured pelvis, my black eyes, split cheeks, cut knees, cut ankles. This has all been because my house wasn't prepared and I wasn't proactive. But now I've got to a point where I'm at the age of 50 years old, where I'm going back to IKEA and I'm buying those sharp edge stoppers from IKEA, from you know, to prevent any cuts that we might get through having falls. So that would be my advice really immediately to anyone listening today, was to take care of our environment and you know, and to try and stop ourselves getting injured sort of you know, not directly because of muscular dystrophy harming us, but the way that our environment is around us. So yeah, and like I said, I have lots of experience with medical professionals, and also the things that we deal with in society and the social access and things like that. So if anyone has any questions, I'm more than happy to answer them after this call. But yeah, like I said, I'm your guy on the inside. I make sure that the limb girdle community is being spoken about and being taken care of by Muscular Dystrophy UK. And by working at Muscular Dystrophy UK, I see exactly where the funds are going, and I'm happy with what I see. So thanks so much for the opportunity, Jackie, Lynn, and everybody else. Like I said, I'm really grateful to hear what everyone said today. It's been awesome.
Thank you, Martin, and thanks so much for sharing that. I think what you've touched on there about that lived experience and actually being able to share your experience of different challenges and kind of navigating different systems is really, really powerful. And you know, at MDK, we kind of really advocate for people to link in with kind of peers and peer support and things like that as well. And in terms of kind of access to environment and adaptations and things, that is things that MDUK can support people to navigate through. So please do get in contact with us. And Martin's already mentioned he'd be happy to link in with anyone if anyone's got any specific questions around that as well. Thanks very much, Martin. So I'll just move on to Rachel next. Rachel, are you happy to introduce yourself and just explain a wee bit about your role and your experience in relation to limb girdle muscular dystrophy?
Yes, thank you, Jackie. I hope everyone can hear me and understand me. Thank you for the invite. It's been fantastic. I share Martin's description there. It's been lovely to listen to Meredith, everybody giving the talks this morning, really powerful talks, especially with Martin, lived experience there. So I worked with muscular dystrophies and closely with MDUK for the past 20 years now. So I'm paediatric and adult. My background's genetic, so and nursing background. So we sort of built up the service within Wales from small start within genetics. So I'm involved with the initial diagnosis of paediatrics, and I've got the honour basically of knowing a lot of families and their extensive pedigree as well, which brings its own challenges for the family, as in when given the diagnosis, looking at other family members and anticipatory management of the condition as well. So I've tried to establish within Wales MTD clinics. So I've got a fabulous team where we work with physios and the consultants, and Lucia from MDUK for the advocacy officer as well. But just not just from the genetic side of things and the clinical management. I think what is important, like has been expressed by Martin and Zoe so strongly, is the psychological impact and the quality of life living with the conditions. So alongside that, a lot of our work, we look at practical things as well as the medical. So looking at like PIP, refers to occupational therapy, whatever it means to ensure that patients have an increased quality of life. So for the past 10 years now, we've been doing conferences, and we run a monthly support session for families with all muscular dystrophies. Sometimes we have disease-specific support sessions. Sometimes we have young person sessions. We've done a limb girdle muscular dystrophy session, Duchenne session, etc. And those have been so inspirational and empowering, just bringing people together to share their experiences, as Martin said, the little tips, like, you know, the sharp edges, protectors, etc. And because especially within Wales, we haven't got much access to psychological services, especially within our neuromuscular services. It is something that we've been lobbying for a while, but it comes down to financial constraints, so we haven't got a psychologist on our team, unfortunately. But from the feedback that we've had from patients and families, the support days have been very instrumental and empowering in supporting people, just sharing that information and building that community. So from those support days, we've had outreach, other things going on, WhatsApp groups created, etc. Cara Stabbage, as you mentioned earlier, has been great. We're getting some of the people on her podcast, and they have got a lot of emotional support from doing that. So that's worked really, really well within our community within Wales. So like from my background, like I said, it's a lot of the clinical background, so nursing support. We run our own nursing therapy clinics and consultant-led clinics. So it's a holistic service. It's not just about the clinical management. I am quite passionate about looking at making sure people are on the registries, building that community, and to manage their care as effectively as we can.
Thanks so much, Rachel. And just to touch on the access to kind of psychological mental health support, I see that there's a question in the Q&A that I'll come back to later on, just kind of touching on accessing that support and the challenges around that. But just to reflect on what you were saying there about the peer support and bringing people together as well, that's something that we've really seen at MD UK as well. I think, you know, peer support doesn't replace access to kind of formal psychological or mental health support, but actually the feedback that we've had from the community is being able to speak and share experiences with someone who understands is so powerful as well. So I know it's not
and the patients and the families are the experts. Not they are, you know, you were living with it.
Yeah, and I don't know, it's not always not everybody wants to kind of link in with that type of support, but you know, if I can encourage anyone, that the feedback we've always had so positive and powerful. Any opportunities for people to get together is really well received. Thanks so much, Rachel. I'll come back because I see there's a couple of questions there, so I'll come back to you once I've introduced this.
Thank you very much, Jackie.
So Alex, if I can just come to you next, just to kind of introduce yourself and share a bit about your role and your experience of limb-girdle muscular dystrophy.
Yeah, absolutely. So my name's Alex. I'm one of the physios at the team at Evelina London Children's Hospital. So we cover the whole southeast, and we're part of the specialist neuromuscular MDT. So it's us as physiotherapists, consultants, clinical nurse specialists, and some other AHPs around us as well. And so our role in the tertiary service is kind of for regular assessment and management of these children and young people all the way from diagnosis, however young that is, through to 18, they transition to adult services. I've also worked in the community as well with young people, so I've seen kind of more of that practical management side on a day-to-day basis, and the challenges that those services face as well. I think one of the big things we face, and just to agree with what Martin was saying earlier about trying to control your environment and reduce risk, is that young people, regardless of their diagnosis, kind of think they're a little bit indestructible. So a bit more risk taking. So trying to encourage them to take more ownership of their condition, to, you know, assess their environment, assess their own abilities. Of course, working with them to maximise their independence, but also to be aware of certain difficulties they might face or might encounter in the future, so they can try and prepare themselves and be prepared for it. Another big thing that we work on with young people with limb-girdle muscular dystrophy is working on pacing and fatigability as well. It can be quite challenging because of the varying patterns and quite global patterns of weakness to find exercises that they enjoy and exercise that they can do the right amount of. We have some young people who want to go above and beyond and be doing so much that they find themselves too fatigued to complete kind of their daily activities they need to do, or interferes with school. Similarly, we have some people who aren't so interested, and their kind of lack of activity is making things difficult. So again, working with services we have in the southeast with certain charity groups and like kind of sports organisations, and access to those to help kind of keep that appropriate level of fitness and engagement with exercise. And similarly with fatigability, there's a lot of education with ourselves as physios and our CNS and advisors around educating schools, a kind of a level of support these young people might need, because sometimes, some days or some periods they might seem quite able, they might be able to write for short periods, no problem, but it's anything that's extended, those long school days. So obviously advocating for the families that these young people need changes that might not be super obvious for, Senkos and things with not a lot of experience in the area. And lastly, the thing we're trying to do more at the moment is joint work with occupational therapists. So occupational therapy is not something that's super kind of accessible or well funded, especially for young people in tertiary services in the neuromuscular world. So we're trying to focus more on the upper limb function, activities of daily living, and really maximising independence and access to the appropriate resources that way.
Thank you very much, Alex. And I know you'd mentioned there about that balance of kind of exercise and stretching and activity and fatigue management and things like that as well. So once I've introduced Shan, I'll come back to you, because one of the questions we get asked quite often is around that kind of the pain, discomfort, fatigue aspect with the activity and stretching and the best way to navigate that. But I'll come to Shan and let Shan introduce herself, and then I'll kind of loop back around to you. Thanks very much, Alex. So Shan, thanks for waiting so patiently. Are you happy to introduce yourself and share a bit about your role?
Yeah, no worries. Thanks for having me. I'm Shan. I'm one of the nurse specialists at Great Ormond Street. I'm very lucky. I work in quite a big team, so I've got lots of different people to ask for help with all my patients' lovely queries. We look after children and their families up until the age of 18, so we're there from diagnosis up until they transition over to adult service. We support. It depends on the patient and the family. We support lots of different ways, whether that's just a chat on the phone after diagnosis, just kind of trying to get families' head around it. We do lots of support with school, lots of support letters for whether they need an EHCP. A lot of it is getting schools to understand the variability of the condition, and as Alex said, the differences on a day-to-day basis. So one day might be harder than the other, and to make sure they always forward plan so that our patients are safe and that they don't feel put out in having to just get those things that will just make their school life a little bit easier, and they can be on the same plane as all their peers. Yeah, we do lots of support letters, lots of liaising with teachers, but we also liaise with other people, colleges, Pilates instructors, clubs, things like that. So yeah, it's a lovely variable job.
Thanks very much, Shan. And just because I'd spoken with you and Alex last there, and you're both coming from a paediatric perspective, so I'd mentioned there, one of the questions we get asked quite often is how parents can kind of navigate that, when children have kind of stretches to do and kind of exercises and activity, but obviously the discomfort of that and the kind of fatigue aspect could be quite off-putting. And it's just, I suppose, is there any advice you could give to families who are kind of maybe navigating those daily stretches or kind of daily exercise, and when they're meeting a bit of resistance from their young person?
No, of course, and there is not one answer for everybody. I wish there was, even with my own children. But it's part of trying to make it a part of the routine, but also an easy part of the routine, whether it's those stretches while brushing your teeth. Sometimes, because brushing your teeth is quite a short activity, I don't know if Alex would agree, sometimes doing your stretches while brushing your teeth is, if you can, is quite good. Also trying to make them fun. Local physios and our physios generally are quite good at making exercises quite fun. And sometimes if that's being done in school as part of PE and things like that, that can really help. But yeah, families can always get in touch with us or the local physios for some ideas. We can always spitball, find some ways to help.
Thanks, Shan. Alex, is there anything you want to add in relation to that?
No, yeah, definitely. Shan's clearly encountered physios before without a brushing teeth remark. That's what we're always saying. But no, I mean, often when it comes to practical things like stretches that were more of a necessity and hard to make fun, it is about fitting them in around your daily life and making what works for different families. And again, with exercise, often it's the right exercise is the one that the kids engage with or the young people engage with, rather than being too prescriptive to try and let them guide the way like any young people do. They don't all like the same thing, so let them try and lead their own way and just help them along that journey.
Mm-hmm. Thanks so much, Alice. And just because fatigue's been mentioned a couple of times, we did have a question about people experiencing severe fatigue. So we'd had a question from someone who said that they experience severe fatigue, which impacts on them most days. is there any advice for managing this? So I could just put that out to the panel if anyone wants to kind of give advice. I know at MDK, fatigue, something that we hear about quite often, has been one of the symptoms that are really difficult to manage and has such a significant impact on people's life because of the kind of variability and almost I think the invisible aspect of fatigue sometimes can be really hard for people as well. So just to put it out to anyone, if anyone wants to offer some advice around fatigue management.
If you want, I can take this, but I guess Meredith or others may want to contribute as well. So there's different aspects to fatigue. Often, so if a patient reports fatigue in clinic, I would look for any other factors that could contribute to it. For example, vitamin D levels. Are there any other comorbidities not related to the muscular dystrophy, for example, thyroid function, sleep? How is the sleep overnight, breathing overnight? Is there any underbreathing, for example, nighttime? So what is the breathing function? And then there is other aspects that are to do with pacing activity. And are you overdoing? Are you doing too much? Some people, for example, they may find like they work part-time, just like they put all of the days together, and so they 3 days in a row and then have a few days off. So what we often advise is to break it down and have maybe a day at work or a half day and break it up a bit so that you pace your activity. And so there could be a bit of overdoing as well. So generally that is how I would approach that fatigue management. I don't know if anyone else from the panel like to add anything.
Thanks, Chiara. Meredith, you're off mute, but I don't think there's no sound coming through. Might be headphones. I'll come back to you, Meredith, and hopefully it'll sort itself out. Alex and Shannon, Rachel, actually, just to come to yourselves, from a kind of paediatric point of view with fatigue management, I know sometimes with children it can be difficult to manage fatigue because there can be a tendency for them to keep up with their peers, want to keep up with their peers and things like that as well. So from a kind of paediatric perspective, is there anything specific in relation to maybe kind of around about school routines or kind of after school activities and things like that as well that might be helpful for people to know?
Yeah, so I think kind of specific challenges in pediatrics is, as you said, especially the younger young people really wanting to push themselves and not being aware of their limits, and then the next day or even the next 2 days being in pain or kind of being so fatigued that just paying attention in school and things is challenging. So in that instance, it's working with parents, working with school to encourage kind of external pacing where you have to tell the young person, okay, now it's time for a break, or in short blocks of exercise, little and often rather than one big bit. And similarly, just identifying, and this will translate to adults as well, what you have on that day, what you need to do that day, what's the most important thing for you. If you're a young person in year 11 coming around to GCSEs time, is actually doing the maximal amount of exercise for you every day at that time the most important thing? Probably not. So it's adjusting the amount of exercise you're doing on a daily basis, on a weekly and a monthly basis to prioritize the things that are most important to you at that time.
Thanks, Alex. Rachel, Shanna, or anyone, Martin, Zoe, is anyone else got anything to add in relation to fatigue?
No, like Alex said, is that about managing the day, the structure and the timing of the exercise basically, but also education as well when we go into the schools to provide education, so that to offload from the families as well, to take that burden off and help them and support them, giving the information to the teachers and the staff in the schools, for them to be able to manage the exercise programs, they PE, for example, if a child wants to do GCSE as part of the curriculum, and how to manage that effectively, just to raise awareness and understanding in the school environment as well. And obviously to liaise with outside school activities as well, if they're doing anything with scouting or whatever it may be as well. So it's about that increased awareness and education there as well.
Thanks, Rachel.
Yeah, I agree with everything. A lot of our children have some adapted timetables as well, so we advocate for our schools to be able to support kids with sometimes they need a slightly different timetable, especially as they're approaching like GCSE, A-levels. They want to prioritise the subjects that are important to them, so that they can excel in the areas that they're passionate about. So.
Yeah, thanks, Shan. And I think you'd also kind of touched on that about the, raising awareness to understand the condition as well, and actually having that tailored approach to each child instead of a kind of blanket approach in terms of kind of managing things. There was a question, so Rachel, you'd mentioned earlier on about kind of access to mental health services and things like that, and someone has put something in the chat in the Q&A about kind of lack of support for patients' mental health, specifically in relation to living with a muscle wasting condition, or a kind of progressive long-term conditions. So they just kind of said more help in this area would be beneficial to help people manage their condition. And I know that's something that everyone will agree on. I think one of the challenges is that services can differ quite significantly across the UK. But also we know that access to that very specific kind of psychological, emotional support relating to living with a muscle waste condition can be really difficult to access. So I suppose just to put it out there, if anyone has any kind of advice around kind of mental well-being, or what people's experience of accessing services might be. So Zoe, I know, had mentioned that about kind of speaking with other people, and Rachel, you'd mentioned that as well, just bringing people together and those shared experiences. So I suppose just to put it out to the panel, if anyone wants to speak from their own experience in terms of what's available or things that might be helpful to people who are living with limb-girdle muscular dystrophy.
I'm quite happy to go. I'm going to pre-warn you, my little sausage dog might bark in a minute, so I'm very sorry
It's
if
no
that
problem.
goes into the background. But I think from my perspective, when I received psychological support, it was linked with the health psychology department with my neuromuscular team. And I found that really helpful and was very lucky that that was available. But I think something that I really learned on that process was definitely not bottling everything up. And the way that I learned to deal with a lot of my anxieties around my health was I used to look at things like, well, what is the worst case scenario? What is it that you're really worrying about? And I would then come up with a solution for that problem. And so then the way that I would look at it would be, well, if I've got a solution for the worst that could happen, anything else is manageable and is okay. And I found that that was a really effective kind of coping mechanism with a lot of it. But the biggest thing that I've learned on this journey, and even just from working in the psychology department, is the biggest thing is support and reaching out for it, and whether that's family or friends or people alike, with groups like this and the other things that are available with MD UK and other charities, just being able to recognize how you're feeling and speak about it. I think it's that old saying, isn't it? A problem shared is a problem halved. And I really stand by that, and being able to receive that support in whatever way works best for you.
Thank you so much, Zoe. Thanks for sharing your personal experience as well. Really appreciate it. Does anyone get anything else that you'd like to add in relation to that?
I could add,
Yeah.
just to acknowledge, yes, there is lack of support and it's very patchy. So there are some centres where there is support. Sometimes it's only available to some subtypes of muscular dystrophy because maybe the funding is available for them. Now we have some support for people living with Duchenne muscular dystrophy, but not all dystrophinopathies, for example, and it's funded through research projects, through charity funding. And in the past, we've had, support declined by different either community services or trust health psychology services, because that funding is not specifically for neuromuscular patients. Now, we as a sort of stakeholders, together with patient organisation, trying to gather the evidence and have had different discussions with regulators, and MDK over the years has certainly campaigned for mental health support. And so I think that is ongoing battle. Now we do, and I think with the registries are well placed. I appreciate there isn't a registry for all types of limb-girdle muscular dystrophy, but the evidence that has been gathered also through some of the research studies will be helpful to then provide that additional evidence to back up why we need mental health support in limb-girdle muscular dystrophies. And that is through different phases. As I was saying, it could be a time of diagnosis, it could be a time of changes in your mobility, respiratory or cardiac function. So it's not that it's necessarily an ongoing requirement of mental health support, but there might be times where you feel it is helpful. So in the meantime, what to do? There is, certainly we can continue refer to raise awareness, and we certainly do our bits to try and obtain that support. And but I think, as Zoe said, the peer supports and resources available through MGK, I think, are still very helpful.
Thanks, Chiara. And just to touch on, so Meredith had mentioned in our presentation about MGK's virtual therapeutic support group. So that's something that we've kind of piloted over the last 18 months or so, 2 years, that have worked really well. So we're working really closely with 2 counsellors and psychotherapists to provide really kind of small groups to access, you know, that kind of guided peer support counselling information. They are very small groups. There is quite a high demand for them, but we kind of release new groups as much as we can, so that information is available on our website as well. I'm just keeping an eye on the Q&A, and I've noticed that there's a couple of questions coming in around pain in relation to kind of posture and mobility and things like that. So I just wonder if I could maybe kind of touch on some of them. So someone had got in contact earlier on to share that their partner has limb-girdle muscular dystrophy and can't get out of bed. Their shoulder blades wing and it causes excruciating pain, so they have no option but to lie on them, and although on strong pain medication, there's still a lot of breakthrough pain, and they're not able to kind of reposition themselves independently. So it's just to kind of put to the panel, have you come across any other approaches that they could try in relation to this?
I think an occupational therapist, seeing them at home, or the district nurse to review what they're sleeping and what equipment might be possible to prescribe to make turning in bed easier, would be my first port of call. And of course, liaising with the local muscle team about what pain relief. But when turning over in bed becomes difficult, it is really common to get very sore shoulders and hips. And so having the right equipment on the bed, the right mattress, we can get electric beds. There's lots of different options out there. But I think the priority would be having an occupational therapist come and see you at home to have that assessment.
Thanks very much, Meredith. Does anyone else get anything to add before I can move on? I think I've seen quite a few questions relating to pain. So someone's put in the chat to say, despite remaining ambulatory, I started to have a lot of pain when I stand for 10 minutes or walk further than 100 metres. For that reason, I stopped physiotherapy for pain during exercise, although they kind of fear losing function and mobility. Should they keep trying or assume that they have no exercise endurance?
I'm happy to take that one. So I think as the muscle weakness progresses and different muscles become more impacted, we can see that walking can become quite painful and difficult for people. And then at that point, it's important to have a discussion with your local team, particularly your local physio, to see if maybe use of a walking aid could become helpful, or even looking at wheelchairs. And we know, certainly for those of us in the UK, that getting the right wheelchair prescription for people takes a really long time. And what we do know specifically in limb girdle is getting out of a standard height chair is going to be really hard, much further ahead of losing the ability to walk altogether. So having something that can stand you up out of a chair, or having a wheelchair with a riser function and things like that, is really important when thinking about wheelchair use in the future, and mobility devices as well, even walkers with seats. everything, just those couple of inches can make the difference between being able to get up and maintain independence or to need to have someone with you. So I would, physio review, maybe there's orthotics as well that could be useful, checking the joint ranges of movement to see if there's any tightness that might be causing the pain. So all of those things could be looked at by a local PT.
Thanks. Martin, do you want to come in?
Yeah, sorry, I just sort of catching up because I had somebody at my front door, but I was just sort of catching up with some of the things that were mentioned here. And I'll just quickly, some of them are just comments really, about the fatigue situation, sometimes you have to be careful of yourself because sometimes too much exercise can be counterproductive. And what I've found myself personally, and everything is personal to every single one of us, is I try to be body economical. So if I know that I need to go get a shower, fill the dishwasher, prep some food for tea, I'll do it in one loop. So I'll make sure that I go get the shower, I get the food out the fridge, it's prepped, ready for dinner, and things are sorted, and then I'll go and sit back down again. So I often think of this term about body, the economy of how we use our body, and how we can sort of use it smarter. So that's one thing that I often consider myself, and also the two things I think that we as a group of people needs more support with from the NHS really, it's which is really hard to come by, is the mental health support, which we've previously mentioned. A lot of us live with muscle wasting conditions, and because of that then suffer with our mental health. So I think that we should be talking about that more. And also hydrotherapy is so hard to come by. It's so hard to come by. I had hydrotherapy way back when I was recently diagnosed, and it was a godsend at the time. So I think that if we could get more people access to hydrotherapy, that would be extremely helpful. And also, again, access to the building to get access to hydrotherapy. This is incredible to think. I literally live across the road from Stoke Mandeville Spinal Unit, and they have a hydrotherapy pool, and yet I have no option to use it. I know it's a spinal injuries unit, totally different case, but surely there must be a pathway, or we must think of how we can make a pathway so people can get access to things like hydrotherapy, because it's massively important. I know that hydrotherapy and physiotherapy is extremely personal. Again, some people are reluctant to, or just find it difficult to really push themselves. And I'm ridiculously positive, and I'm extremely lucky to have a PT that is a world championship kickboxer that gives me 2 hours a week just to get me literally moving on the mats, whether that's in the wheelchair with sparring, or out the wheelchair walking around the dojo, because these mats are so thick that I'm in the safest environment possible. But yeah, I mean, sorry, I digress. But to me, especially for people recently diagnosed, I think hydrotherapy is a pathway that needs to be opened.
Thanks very much, Martin. And I think what you were saying about kind of being economical with your body. I've not heard that term before, but it makes complete sense. And it kind of falls in line with the kind of planning, pacing, prioritising of fatigue management as well. And just on hydrotherapy, so there is actually a question in the Q&A about hydrotherapy. And I know that that's something that we hear about often, but someone has said pre-COVID there was access to hydrotherapy, but now it seems to have been done away with. Do we know if we can apply for this to be reinstated? I found this service good for pain management and maintaining working muscles. So I know access to hydrotherapy, I think, is a challenge across the UK, and it can be very dependent on what area that you live in as well. And I know that that's a real frustration for people. My advice would be, and I'll come to the panel in a second for their thoughts as well, would be to explore the options and have those conversations, because like Martin says, those facilities are available in your community. I think because of different pressures on services, the criteria for accessing them has changed quite significantly and it's become more challenging to do that, but it's worth having those conversations and kind of pressing to find out what you're entitled to. We can also signpost to kind of local hydrotherapy kind of that you'd have to privately purchase, but it is worth kind of re-exploring it. But I know across the UK access to hydrotherapy continues to be a challenge. Rachel, do you want to come in on that point? Oh, sorry. You're muted, Rachel.
Okay.
Yeah, that's
Yeah,
you.
sorry, thanks, Jack. I'd just like to say, the other teams are probably aware as well, but within Wales, within South East Wales, we've got a hydrotherapy pool, luckily enough, in our centre now, that we do rolling programs for our patients. But it's not equitable across Wales at all. So in the past, I've sort of tried to facilitate hydrotherapy utilising private hospitals, and there's a small payment sometimes, but they've got hydrotherapy pools, so we've accessed those, or just signposted to local councils we've done a project recently looking at what the temperature of their pools are, if they're warmer, and then looking at some aqua classes there that perhaps people could access, and looking at the accessibility of local pools as well, because like that person asked in the chat there, she's in Northern Ireland, but so obviously I don't know what's available there, but just doing a bit of exploration with their team, because that's what's powerful about the peer support groups as well. You know, people can share that information as well if they've come across something. Some spas have reduced rates, etc. So sometimes it just takes a lot of energy looking what's out there.
Yeah, no, absolutely. Thanks, Rachel.
Oh, and can I just say as well,
yeah.
if they look at if they have got a local hospice, I know I have worked with our local hospice and just asked them basically if we can utilise their hydrotherapy pools outside of ours, which they've been amenable to in some cases. So perhaps that's an avenue to explore as well.
Yeah, definitely. Thanks very much, Rachel. I'll just move on. So there's a couple of questions that I'll just pick up on. So someone in the chat said they were diagnosed with limb-girdle muscular dystrophy 2A, and they find it really challenging to sleep well due to the pain they're experiencing. Is there any advice that anyone can give them in relation to that?
We answered that before.
Were you gonna go, Rachel? Or...
No, I was just trying to remember, but I was going to say, I thought we answered that. I was just going to say the same as Meredith. Look at the pain management, look at the practical issues, you know, orthotics, the bed, tilt and turn bed, sleep systems, try to explore, look at everything holistically, look at the sleep hygiene, look at there's any contributing factors, low iron levels, etc. I'd probably look at the bloods, look at it from a medical as well as a holistic point of view as well for the equipment, etc.
Thanks, Rachel. So there's a question in the Q&A about research in relation to nutrition and special diet that might improve the condition. I don't know if anyone wants to come in and answer that one. Is there any research in relation to nutrition and special diet?
There aren't any specific studies in limb-girdle at the moment looking at nutrition and diet, and our recommendations would be essentially to follow, healthy government guidelines, eat a good variety of fresh, unprocessed food. There's been questions about whether you can just supplement with lots of protein and that would replace the issue with the muscle. It's not. There is absolutely no evidence for that whatsoever. So our advice would be a balanced diet full of fresh food.
Thanks, Meredith. And we received a question this morning in relation to limb-girdle and the different subtypes that there is. So someone had asked, how is it possible that limb-girdle can vary so much within the same family? And is it possible that family members could have different subtypes of limb-girdle muscular dystrophy from each other?
I mean, a double trouble can happen. Highly unlikely, but highly, it's very, very rare. We have some families where you have two neuromuscular diseases occurring, so it's not impossible, but it's actually more likely that there is variability, that we are different. We carry the same exact misspelling within the same family, but everyone has a different journey, and so we are aware that there is variability. So it's not quite a like for like.
Thanks, Kiara. So someone's just put in the Q&A there about the supplement D-ribose being used for muscle recovery. If anyone has a comment in relation to that.
I was just going to continue from Chiara's comments around the different siblings. And this is why natural history is really important, because if we know you've got the same genetic mutation, but you look very different to your sibling, understanding what the factors are that influence that is really important to us as clinicians to be able to drive research in the future as well. So that's one of the areas of interest in all of these natural history studies, is trying to have siblings in so that we can better understand how things change. As to D-ribose, the ribitol study, so the study from Elmo Bio for FKRP is looking at something very similar, but that's specific to limb-girdle R9.
Thanks very much, Meredith. And then, so a question just to put to the panel, anyone who wants to answer it. Someone had asked is there any advice that you can give about the transition from having to use a wheelchair more regularly or full time? So I'm assuming that that's in relation from a kind of emotional perspective as well. So if anyone's got anything that they can advise around that, that transition to using a wheelchair more regularly.
I don't really have advice, but I can tell you about my lived experience. I was in a place where when I was ambulant out and about, I remember I was on the Isle of Wight with my family, and my girls wanted to go to the zoo on the Isle of Wight, and I was tired because I'd worked so much the day before because it was a holiday. There's lots of traveling, etc. And I saw my girls so I sat in my car in the disabled bay and looked through the gates of the zoo and saw my girls having a great time without me. And so after that holiday, that was when I'd come back to home and decided that it was my time to try to use a wheelchair, and I did, and it was a very similar situation to when I first got my wheelchair accessible vehicle. It's stages that we go through, and it is absolutely and entirely up to an individual. When I was being asked by my wife, when I was using a walking stick and sticks and struggling, and my wife was saying, about a wheelchair, I was extremely stubborn, and I was saying, absolutely not. There's no way I'm going to do that now. And also, like I said earlier, my brother lives with the condition, 2 years older than me, 2 years further down the line, and he was a wheelchair user probably 10 years before I even contemplated it. So it is an extremely personal thing. I was always thinking about it being a negative experience, moving from being ambulant to into a wheelchair. And then it happened, and then I thought, why did I not do this before? But it is an extremely emotional thing. It's part of living with muscle wasting condition, and it's something that every single individual will have to make their mind up on. A medical professional can do it, a loved one can do it and ask and request, and still it will be up to that person. And when that person does it, and when that person makes that decision, you have to absolutely wholeheartedly support what they're going through, because it might not be as easy, and it might not be as life-changing as it was for me. So yeah, I haven't really got any advice apart from just if you're not the person living with the muscle wasting condition, if you're someone supporting the person living with muscle wasting condition, then just, excuse the irony, but tread carefully and try and be as supportive as possible. And also remember, the services that are open to us, like the Joseph Patrick Trust and things like that. And also, there might be somebody in the community off of this conversation today that you might be able to talk about, and they might have equipment that you could probably or might want a test drive beforehand. So think about the opportunities that we have from things like today. And that's about it, really. Like I said, I can't really advise people, but I can tell you about my experience. And like I said, it's extremely personal and an emotional one.
No, thanks, Martin. Really appreciate that. And someone's commented in the Q&A as well to say that transitioning to a wheelchair was really difficult at first, but the more you accept that it's there to help you and it's an aid, it'll give you independence and freedom, and it will change your life for the better. So I really appreciate those comments. Just because you'd mentioned the Joseph Patrick Trust, Martin, and actually someone had commented earlier to just ask us to what that was in relation to. So the Joseph Patrick Trust is the welfare grant giving arm at MD UK that can fund towards mobility equipment. So that information's all available on our website about what the Joseph Patrick Trust can fund, and I'll ask for that information to be shared after the seminar with anyone who's dialed in today as well. I just wonder, Alex and Shan, I just wonder if you, and Rachel actually, if you've got anything, any kind of comments specifically in relation to, you know, kind of young adults, kind of teenagers. I know that sometimes, like Martin was saying, that it's such a personal thing, and we should be led by, you know, someone who's living with the community. But I know situations in the past maybe where the risk around falls, particularly in relation to children, has came up. So that kind of balance of the risk of falls, particularly maybe in kind of school or education settings, and actually, you know, the child remaining kind of independent and things like that as well. So I just wondered if there was any comments around kind of navigating that for
I
families.
mean, what I try and do and what we try and do is focus on what you can do or what the young person can do rather than how they can do it. And I think that can be an important way of trying to help that frame shift. As Martin was saying, it's an enormous decision. It's a big kind of visual reminder for the young person and the parents of the disability, but trying to focus on, again, what you can do, not how you do it. You know, this will allow you to do more, allow you to access more things with your friends, it'll allow you to access the playground independently, allow you to access your Legoland all day without being fatigued and worrying about falls. So trying to change that focus as well. And just to cut back briefly to a bit more practical thing about the wheelchairs as well. If you are moving into using a wheelchair more full time, obviously the NHS provision is patchy, and some of the wheelchairs or what they can offer will not always meet your needs. And if there are things that you see privately, certain companies that you encounter anyway, don't be afraid, just contact them directly. We've had a lot of parents and young people have a lot of good experience with just seeing something, finding the contact details, and a lot of these smaller companies, especially ones that have been set up by or have a lot of involvement from wheelchair users themselves, are very amenable to coming out and letting you test them and things. So it's a little bit of a, sometimes if you don't ask, you don't get. So don't be afraid to contact any companies directly.
Thanks, Alex. Shan, Rachel, do you have anything that you want to add in relation to?
No, just that it's really variable between people, their own experience, like Martin said. We encourage families to have the conversation early, just to have that out there, because surprises are scary and change is scary generally. So with kids, we'd like families to have those conversations before you're kind of almost before you need them, because it means that you can think about how it will benefit you before it's imminent, which is always nice.
Rachel?
Yeah, I think we've had a couple transition into uni as well, or college, and I think that's really important to explore then. So I've liaised with the welfare office in the uni to look at the accommodation, to look at the suitable, look at accessibility, obviously, to where the lectures will be, and transport as well. So liaising with the university to look at, could they have a grant for transport if it's a campus which they've got a long way to navigate to the lectures or the halls, etc. So it's looking at the practical issues with funding, what accessibility they can have, or they can access from the uni or the college as well, and to, again, education awareness is paramount to support them and the family as well, because it's a very tricky time to navigate, and whether they need to look at a care package as well and what that looks like. I know it's different in England and Northern Ireland, etc., and Wales with regards to direct payment, etc., but sometimes that can be helpful as well if they need a PA.
Thanks very much, Rachel. And you'd mentioned accessing funding and things like that as well. So if people are looking for funding and it's something that MD UK can't support with through the Joseph Patrick Trust, we're always really happy to work with people to make sure they have access to kind of other funding options that are available as well. So we're nearly at the end of today's seminar, but there was just a few things I wanted to kind of touch on that were mentioned in the chat. So lots of comments around Keris's podcast, Unbalanced. So we'd mentioned that earlier on. We can share the link about that after, and someone had said in the comments that they find that connecting with others is the best way to kind of navigate living with limb-girdle muscular dystrophy, and hope that you can find some comfort in Keris's podcast, which discusses all aspects of life with limb-girdle muscular dystrophy. So we can share the link to that after. We'd already kind of mentioned Joseph Patrick Trust, so that information is all available on our website. I just wanted to mention, because there was a couple of questions around employment, so MDUK do have an employability helpline that people can access as well. So again, that information is available on our website, and we can share that with attendees after the seminar also. And just a final point for me before we finish up is MDUK is just in the process of reviewing their information, and we have just kind of overhauled our alert cards. So we do have some new alert cards as well, specifically for limb-girdle muscular dystrophy. Again, available on our website, but we will send out information about that as well. Rachel, do you want to come in?
Can I just add, I know I'm not plugging Keris again, but the podcasts are fantastic. But within our groups, we have talked in what is, especially for transition and adults, children, both looking across the board, is relationships as well and intimacy. And one of our, he's actually a young gentleman with Duchenne muscular dystrophy, but some very similar challenges with regards to relationships, and he's done some podcasts and actually some documentaries which have been televised on S4C and are on YouTube with regards to relationships, sex and intimacy and living with disability, which have been very positive feedback if anybody's interested in looking at those.
Thank you very much, Rachel. Has anyone got any final comments today before I bring us to a close? No. So unfortunately, that's the end of today's session, and I just would like to thank all our panelists and the people who helped to guide the discussions with questions and comments. So you can see recordings of all our other seminar sessions on our website and our YouTube channel. And as I'd mentioned at the beginning, the recording of this session will be posted on our YouTube channel later this week. We'll also be in touch with a very short survey just to gather some feedback on the session, which is really valuable to us as we shape how we do these seminars in future. So just a reminder that MDUK's virtual information seminars are a source of information but shouldn't replace direct advice from your own specialist consultant or health professionals. If you have any concerns, you're advised to speak with your own neuromuscular clinical team or health professional directly. So just a huge thank you again to everyone for joining us and for your input today. Thank you very much, everyone.
Thank you.
Bye.